Hello, good evening, welcome everyone. Thank you for joining us tonight for our next Living with COVID webinar update. Tonight's topic is post-COVID conditions and rehabilitation. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I'd like to begin the session this evening by acknowledging the First Peoples and traditional custodians of all the lands in which we are meeting on tonight and pay my respects to elders past, present and emerging. I'd also like to acknowledge that I'm on Awabakal country. So tonight's session, like our other webinars, is being recorded, and the recording and the presenter's PowerPoint slides will become available from tomorrow in our education library on our website. So to access these, you just head to our homepage, thephn.com.au, and click on the Education tab. There will be a short evaluation survey that'll automatically pop up when the webinar ends. If you could just take a minute to fill that out before you log off, we really appreciate any feedback that you can provide us. So please type your questions in the questions box at any stage throughout the session this evening, but please know that we have allocated some time after all of our presentations to have a Q&A panel discussion. That's all from me. I'll now hand over to Kimberly Booth, who is a Manager for COVID Response with the PHN. Kim will introduce tonight's speakers. Thanks very much, Kim.
Thank you, Charles. I too would like to acknowledge the traditional custodians of all the various lands that we're meeting on tonight and pay my respect to elders past, present and emerging. So we are lucky enough tonight to have some pretty awesome speakers. As usual, we have the wonderful and amazing Dr. Michelle Redford from Black Buck Doctors. We also are going to be joined by Conjoint Professor Peter Walk, who is a Senior Staff Specialist in Respiratory and Sleep Medicine at John Hunter Hospital, and Professor Stephen Foe, who is the Rehabilitation and Pain Physician at St Vincent's Hospital. And we are also very happy to welcome Eden McNeil, who's an exercise physiologist with the Hunter Rehabilitation and Health. And we have a little late entry being Sandra Fitzgerald from the PHN representing Health Pathways. So thank you all, enjoy, and I will hand over to Michelle.
Thanks very much for that lovely introduction, and I'm going to get straight on to COVID hot topics. So I'm not actually talking about post-COVID conditions. I'm talking about just what's changed since we last had a webinar. So I'm just going to race through some of this and then we will move on to the post-COVID conditions. So just a little quick update. So this is where you can find the frequently asked questions for general practice. This is on the PHN website. It is also linked from Health Pathways. This is what it looks like on Hunter New England Health Pathways. It's just as a link at the top of the care of the COVID-19 positive adult patients in the community. This is what it looks like if you're on the Central Coast. It's just down there at the bottom under local guidance. So hopefully everyone can find those things when they need them. I'm going to sort of go through a few things that have changed since we last talked. That's the little list. There's quite a few bits and pieces. Some of it might be getting a bit old news now, but it's just to clarify some of the things that are coming up. So this comes from New South Wales Health's social media page, and it's just really to alert GPs that this is the process now, that when patients register their positive RAT or they have a PCR test that's positive, they get sent an SMS survey. And depending on the results of the answers to those questions, then some patients will get a secondary survey to identify whether they're at higher risk. And that's to try and screen out patients that may be eligible for oral antivirals. And so you may actually be contacted by New South Wales Health or Medibank Private, basically, who's the call centre. They might contact your surgery and say, is there a GP available that can assess this patient and provide us a prescription? And of course, that is not a completely quick, easy, straightforward process, as indicated maybe in the slide, but just to know that that could happen and probably maybe is already happening in various parts of the patch. So when we're talking about prescribing, just to note that the ACI criteria for medication have changed. And this is my quick summary so that you can quickly filter out the ones that you need to think about. So if patients are immunocompromised, and by that I mean well, that we're taking to mean essentially that you were going to give them 3 doses for a primary course of vaccination, roughly that group, then really those patients need to be referred to your LHD service, because they're going to be the higher risk patients, and then they will decide what medication they need, if any. And then the next group, so once you've worked out are they immunocompromised or not, then the next question is, are they fully up to date with vaccination? If they're fully up to date with vaccination, then really, and they're not immunocompromised, then they're not eligible for medication, so you can stop worrying about it. If they're not up to date and they're within 5 days of starting symptoms and they don't need oxygen and they have 2 risk factors, then they may be eligible. And then this is where it gets a bit more complicated. So these are the ACI guidelines. I'm not expecting anyone to memorize them. I think you need to know where to find them. They're on Health Pathways and they're also on the ACI website. So that's the criteria for sotrovimab, and this is the criteria for the 2 oral antivirals. Now, the other thing, this is my summary slide of which drugs you might consider first and second line. So essentially, first line is sotrovimab and Paxlovid, which is nirmatrelvir plus ritonavir, and Lagevrio is definitely second line. And it's just summarizing some of the kind of key prescribing considerations, really. So that's available, that's in the FAQ if you need to find it. So the other thing that's changed is that molnupiravir, Lagevrio, has become available on the PBS, which means that potentially it may be available via community pharmacy. But the PBS criteria, of course, are not an exact match for the ACI criteria. And so with all things PBS, we use our clinical judgment first. And so in this case, we'll be using the clinical criteria, which are the ACI criteria. And just remembering it's second line, and it's for high-risk patients. The evidence comes from studies in patients who were not vaccinated. And then these are some other things about it, that it's an expensive medication. So community pharmacies are not going to have lots of this sitting around on their shelves, good to go. So if you do end up prescribing it on PBS through your clinical software, because they're now set up, apparently, so I know best practices, but I think medical director is as well. If you're going to actually generate a normal prescription for it, you need to know that your local pharmacy has it and can get it to the patient. And just bear in mind, there's all these resources about prescribing, lots of information out there, including the NPS, which has gathered a load of resources. But once again, Health Pathways is your go-to. Any patients that are high enough risk to have oral antivirals, I would suggest need clinical monitoring via telehealth and a pulse oximeter as well. So this is just my comparison of the ACI criteria versus the PBS criteria. And again, the detail isn't necessarily something that you're going to get across, but you need to be able to reference this sort of information if you're prescribing these drugs. So stick to the ACI criteria. Just because they meet the PBS criteria doesn't necessarily mean it's a good idea clinically. Okay, enough about antivirals. New South Wales Health moved to an amber alert some time ago that generated lots of questions about what should be happening in general practice. So certainly in our situation in Newcastle, there is lots of virus about. The characteristics of the virus haven't changed. We still are in P2 respirators and eye protection for all clinical contact in small rooms with the windows open. And this is just taken from the IPAC manual and just says that whole thing again of, yeah, we are still in masks. Masks are not gone. And we are still using, we're still asking all our patients to wear surgical masks just to reduce transmission. And a lot of that is about, we don't want the whole staff going down with COVID all at the same time and not having the ability to provide a service. So we're trying to slow it down. And that's just come straight off the New South Wales Health website, that it is still okay to ask people to wear a mask. This is about isolation. So self-isolation rules. This is another slide from New South Wales Health's social media, and it just has simplified slightly the ideas about household contacts. So household contacts no longer have rolling isolation. you know, whereas before there was that issue, if you hadn't managed to isolate from the COVID case in your household, then you had to remain in isolation until 7 days from your last contact with that person. And so potentially you could have a household with rolling isolation over a prolonged period. So that has gone, and now everybody is just in isolation for the 7 days from the case's first positive test. So still not from symptoms, but from the positive test. And household contacts do not need to go through another period of isolation within the following 14 days. So that's the current rules. And there's been a lot of stuff about, because National Cabinet signalled that isolation for household contacts was finishing. That hasn't yet come into force in New South Wales, as far as I'm aware, unless it happened late today and I didn't get caught up with it, but still waiting for that one. The other thing that's changed is that the New South Wales Health clearance documentation now clearly states for patients that it acts as a temporary exemption from mandatory vaccination under public health orders for 6 weeks. So we should be encouraging our patients to get any vaccines that are due, you know, 4 to 6 weeks after they have de-isolated with their COVID infection. And I think that's been pretty established for a while now. Just a note, in bearing in mind the floods, that you can leave isolation in an emergency. You can also leave to get a COVID test, like if you're a household contact and you need to go and get a COVID test because you don't have a RAT, or you're a high-risk person and you need to get a PCR, and also to seek urgent medical care that can't be done over telehealth. The other thing that's changed is that the 4-week window for not needing testing. So this is after you've actually had COVID-19. So previously there was a 4-week window when you didn't have to self-isolate if you came into contact again. Now it's 8 weeks, and within 8 weeks you don't really need to be tested. And if you're a healthcare worker or something and there are testing requirements, then generally that's not going to be enforced in that 8 weeks. On to immunization. Just a quick summary of boosters. So remember, still no boosters at all for under 16s. There may be some immunocompromised children aged 5+ who require a 3-dose primary course, but there are still no boosters for under 16s. 16 and 17-year-olds can't have Moderna, they can only have Pfizer. 18+, Moderna and Pfizer are preferred. There's not particularly any particular push for one over the other. And Aci have now said you can have AstraZeneca if mRNA vaccines are contraindicated, but not if you've already had 2 AstraZenecas, because that's probably pointless having 3 AstraZenecas. So in that situation, if you've had 2 AstraZenecas and you can't have an mRNA vaccine, then maybe you could have Novavax as a booster, because now you can give it if no other vaccine brand is suitable. And just in the last week, that has been TGA approved. We had a weird situation with that where Aci were recommending it, but TGA hadn't approved it, which is the opposite way round to normal. But now that's all fixed up and in sync. But if someone has already had 2 AstraZenecas and then another AstraZeneca, then you still don't need to do anything. But just, you know, if you find someone who's had 2 AstraZenecas, then give them an mRNA. Mandatory boosters have come in for staff in aged care facilities, and that's the criteria. It's also come in for disability care workers, or it's coming in. I haven't seen the public health order, but it's on its way. Vaccine exemptions, just a couple of little changes. A positive RAT that has been reported to Services New South Wales is now acceptable evidence of infection for a temporary exemption. Previously it was PCR only, and now you can do it on a RAT if it's applicable. The New South Wales form that we had before, the exemption form, is now no longer valid. Only use this form, the IM011 from the Australian Immunisation Register, and you have to upload it via PRODA. So that's a little bit of fun. Moderna has also come in for 6 to 11s. It feels like this was ages ago, but it has actually happened since we last did a webinar. And there is a vaccination course on the vaccination training about this. So it's half the adult dose, same as the adult booster dose, 2 doses 8 weeks apart, can bring it down to 4 weeks if you've got a high-risk child or someone who's going to be traveling. 3-dose primary course, same as the other vaccines. And same as with Pfizer, you give the correct vaccine for the age that the child is on the day. There's a specific thing saying, please don't try mixing Pfizer and Moderna because we haven't got any evidence for that. You can give it with other vaccines like flu vaccine because we're all going to get stuck in with that soon. And if you're 5, the only vaccine you can have is pediatric Pfizer, and there is no vaccine for 4-year-olds and younger. A couple of things that came up in the questions. So how common is PIMS-TS? ATAGI reckon is nearly 1 in 2,500, which is a lot more, sorry, not 2,500, yeah, 2,500, yeah, sorry, which is a lot more than I thought it was going to be. But that's in one of the ATAGI documents. And then there's this thing about elective surgery. So just to be aware that if your patient has had COVID, their elective surgery may be postponed for up to about 7 or 8 weeks after their diagnosis, because there is an association with increased mortality in patients undergoing surgery in that window. So just to be aware of that. This is just a quick plug for my Kahoot, because you want to do some little quizzes about COVID-19 vaccination in your spare time. So this is the link, and it's just a bit of fun. And if you're going to do it, don't put in your real name. If you have got questions you'd like to submit, then this is the link. It's also on the PHM website, and we're always happy to answer questions. And I'll be here at the end to answer more questions. That's it from me. I think I am handing over to Stephen. Is that right, Charles?
We know we're going to go to Peter next. So thanks, Peter, if you'd like to jump on, and you should be able to see my screen now with your slides.
Can you hear me now?
Yes, yeah, we can hear you, Peter. Can you pop your camera on as well?
Yes. Yes, sorry about that. I've forgotten how to use the platform. Too many platforms anyway. Thanks everybody once again for inviting us along tonight, and thanks for everybody else here. I'm just going to touch upon post-acute sequelae of COVID-19. I'm sure many of you are starting to see these patients, as are we, and might have some questions. New South Wales Health has a clinical practice guideline, which is undergoing revision at the moment, and hopefully is not very far off from being completed. That's informing and will continue to inform the information that's provided on health pathways, and so we're making sure that the documents that we do put forward will align, and you'll be able to get further information and links that way. So next slide, please. I'll just also acknowledge the lands upon which we're meeting are the traditional lands of the Awabakal and the Wirramai people, and acknowledge elders past and present. Next slide, please. So we know what acute COVID is, but those people who've got post-acute sequelae of COVID, this is a fairly long, convoluted definition from WHO. It really says persistence of symptoms that occur within 3 months of the onset of COVID and last for at least 2 months and cannot be explained by an alternative diagnosis. So it's important to obviously rule out secondary causes, other things that might go on, and that time frame is also fairly important. Symptoms that persist after the acute phase are really quite common, certainly within that first window of 4 to 8 weeks. And so this is a rather arbitrary division, but it's just an attempt to try and put some clarity around this, and also to have some consistency in reporting. So obviously this is a continuum. You don't necessarily have to wait for someone to reach 12 weeks before you decide that you're going to investigate them or look into their problems, but it's just helpful to keep these definitions in mind. Next slide, please. So the most important thing is that this is a fairly rapidly evolving field. Both the signs, symptoms, and treatments of post-acute COVID are really evolving rapidly. And hopefully, of course, our evidence base at the moment in both of our understanding as well as management is also going to evolve, because this is a completely new condition and one for which we have very little idea as to how to investigate and manage. Pre-Omicron, there were prevalence rates of anywhere between 40 to 60%, with much higher rates reported in the hospitalized and the acute, people undergoing the acute phase of the illness. Now, Omicron, this is all rather unclear, but as you'll see, the most important reasons that someone will develop acute and then go on to develop post-acute COVID syndromes are also very closely related to how severely unwell they are. So one would hope we are not going to see the large numbers that we've seen earlier in the pandemic translate through to where we're now seeing quite high numbers of acute illness. It is also fairly clear and becoming increasingly clear that vaccination is protective, certainly at reducing the incidence and severity of the acute illness, and also by reducing the incidence and severity of post-acute COVID. Next slide, please. So the factors that increase the risk of post-acute COVID, well, as I said, they're really about the severity of the acute illness, and there is a very close relationship to how unwell people are from acute COVID, and they're going on to develop those more severe chronic symptoms. So hospitalization, age, pre-existent medical problems and frailty, vaccination status, an increased severity and an increase in inflammatory markers that have been measured during the acute phase all seem to be important predictors, and female sex. Next slide, please. So the mechanisms behind post-acute COVID remain unclear. There is quite an evidence base evolving around this, particularly organ dysfunction, which has occurred as a direct result of the acute illness. Certainly that is a very important driver in much of the parenchymal disease associated with lungs. The persistent hyperinflammatory state has been implicated in neurological complications, as well as some of the musculoskeletal problems, and of course, what we'll mention with some of the acute cardiovascular problems as well. Medications, prolonged hospitalization, all of these things, of course, also take their toll and not surprisingly impact upon longer-term symptoms in those that are recovering from this acute illness and any acute illness. Next slide, please. So the clinical practice guideline, which is in development, is going to scope out this. Really, the document's going to be informed by the evidence as it's evolving and will be updated on a regular basis. It's targeting all New South Wales clinicians, both in primary and secondary care, and it is to try and bring some alignment in options to refer patients, options to investigate them, and the treatments that we might be able to recommend. Next slide, please. This will be aligned very closely, as I mentioned, with health pathways. And here you can see the 10 most frequently reported symptoms. Now, in all fairness, these aren't in any particular order, but things such as fatigue, breathlessness, cough, depression, anxiety, more specifically PTSD, cognitive impairment, musculoskeletal and joint problems, impaired mobility, palpitations and chest pain, and persistent loss of taste and smell are really very common symptoms in this group of individuals. And I'll focus mostly on breathlessness next. Next slide, please. So in that early phase after the acute illness, certainly that first 3 to 6 months, breathlessness really does take a fairly important role in the number and the severity of people presenting with these more severe post-acute COVID symptoms. This is not at all uncommon, and within the first few weeks of discharge from hospital with acute COVID-19, persistent breathlessness is really very, very common. However, by 4 to 8 weeks, we should start to see a significant reduction in the prevalence of people describing breathlessness. And we could see that this starts to stabilize around that time period with a prevalence of around about 14 to 37%. People may complain of exertional breathlessness alone or breathlessness which is present all the time. Early on, it can be very difficult to directly relate this to measures of respiratory function, but it can still be quite debilitating. But as you'll see, there are some investigations which can be really quite helpful in determining the nature, the cause, and what investigations we should do. Whenever you're questioning someone who presents with a post-acute COVID syndrome, remember to ask them about the severity of their acute illness, what, if any, acute complications they may have had whilst they were an inpatient or during the acute phase of their illness. Certainly the level of their respiratory support that they required during their illness is a very important factor in predicting persistent breathlessness, and those who have needed support with high flow oxygen, CPAP, or support in intensive care, not surprisingly, are those that suffer the most severe breathlessness consequent to that. And of course, the presence of pre-existent comorbid cardiac or respiratory disease are also critical features in ongoing symptoms of breathlessness and exercise impairment. Next slide, please. So these are two studies that I just want to bring to your attention. The first is a meta-analysis on the left-hand side there that was published late last year in JAMA by Goff. And it just looks at the number of respiratory symptoms that people are describing up to 8 weeks, between 8 weeks and 6 months following their acute illness. So you can see that breathlessness or dyspnea is mentioned quite widely, and you've got prevalence rates there of around about 30%. Cough is also quite frequent as well at around about 13%. And then you can see some important differences here between some of the lung function abnormalities we may see and the symptoms that are present. So I'll skip to the second one there, and measuring spirometry and finding that people have what we call restrictive spirometry. So their FEV1 and their FVC are both reduced, is present in probably about 10% of people, but around about 30% of people are complaining of significant breathlessness. So in order to find lung disease, which is attributed to this breathlessness, you probably have to look a little bit harder in those people complaining of significant breathlessness. And measurements such as pulmonary gas exchange by measuring a DLCO, which can be done in your lung function laboratories, is a better correlate to what people are describing in terms of exertional breathlessness. And you can see those prevalence rates again are around about 30% will have some abnormalities in their DLCO. Of course, if you go on and do high resolution CT scans, you find lots and lots of things. You find ground glass opacities. They're worse in the first few weeks. They gradually get better. Disturbingly, some people are left with persistent abnormalities on CT scan and persistent disease, which really is a form of interstitial lung disease 12 months after their acute diagnosis. And you can see this in a lot of individuals, so around about 23% with significant acute respiratory disease. But what you're going to do about it and how it impacts upon their day-to-day functioning is another matter. So this is an article on the right-hand side, still in preprint, from the UK ILD study. So it's taken over 3,000 individuals who are admitted to hospital with serious acute COVID, looking for how many will go on and develop serious interstitial lung disease. And they've looked at them around 240 days post-discharge. They had spirometry, DLCO, and a chest X-ray as their initial assessment. And they then looked, based on those factors, what was the risk that these individuals might have substantial interstitial lung disease on a CT scan. So they determined from using those screening tests that only around about 6.9% were at high risk. And if you were found to be at high risk, you are very likely to have abnormalities on a CT scan that were important, around about 85%. So having that first step where you ask someone about persistent and significant breathlessness, doing a chest X-ray and looking for abnormalities, and doing spirometry together with DLCO is a pretty good screening test and should mean that most people do not need to go on and have a CT scan of their chest, exposing them to 8 millisieverts of radiation and costing around about $750 to $1,000 for every scan, as opposed to $110 for spirometry and DLCO. Next slide, please. So if you've got people who present 4 to 8 weeks after their acute illness, they're still complaining of significant breathlessness, which is worse than their pre-existent comorbid state. This is impairing their exercise tolerance, moderately at least affecting their day-to-day functioning. Well, I think consider looking into it further. I'd recommend that they have some spirometry, DLCO, and a chest x-ray. And if those things are abnormal, then they should be referred to a service to be seen by a respiratory physician, and they will then go on to have a high-resolution non-contrast CT scan to quantify and estimate the amount of interstitial change which is present. If that's not abnormal, and despite them being significantly breathless, well, think of other things that may be causing their breathlessness, and we'll come to that in a minute, particularly cardiovascular disease. If their breathlessness is only mild, well, you can investigate as you feel is appropriate, but really think about how much good that's going to do. And that would be quite reasonable in people with persistent breathlessness after their acute COVID illness to refer them to community physiotherapist or an exercise physiologist and under a chronic care plan to get them back on their feet and get them back doing the things they are normally doing. Next slide, please. So what if their breathlessness gets worse? So if they've got worsened breathlessness after this acute phase? Well, there are unfortunately a number of conditions which are more likely to occur in the post-acute COVID space, and pulmonary embolism is one of them. Again, going to JAMA, this is a nice, fairly large study of over 2,000 people post-hospitalization with COVID-19, and they were assessed for up to 90 days post-discharge. Around about 1.3% of them had a thromboembolic event, 16 PEs, 18 DVTs, and interestingly, 2 portal vein thromboses. And the risk was greater if they'd had a previous history of DVT and PE, or if they had a hyperinflammatory response during the acute illness, and of course you may not know that, or they had a very strongly positive D dimer. The risk, of course, of DVT and PE was less in those who are anticoagulated following their discharge. But you can see if you look at the graphs here on the right-hand side that most of these events are occurring certainly within the first 30 days, and it starts to tail off quite significantly by the time you reach day 90 post-presentation. So next slide, please. So if you think someone might have a PE, sure, new or worsened breathlessness, then assess it the same way you would assess anybody with a pulmonary embolus. Do your pre-test clinical probability. You could still use tests like the Wells score, etc., to try and ascertain that. Obviously, they don't ask you specific questions about COVID, but I guess you can add that in there. And there is still value in doing a D dimer. Depending upon how close that is to the time of their discharge, it may still be positive. You are correct following their acute illness. But if it is, then, and you've got a reasonable pre-test clinical probability, that should trigger you to the next step of investigation with either a CTPA or a lung ventilation scan. If it's a low probability, if their D dimer is negative, they haven't got a PE. Just the same as any other risk factors for PE, that would be extremely unlikely. You shouldn't have to go on and do a CTPA. Next slide, please. But really just to highlight the importance that not all new breathlessness may be due to lung disease. And in fact, this fairly large review of over 150,000 US veterans and their post-COVID burden of illness for up to 12 months after the acute event shows very significantly the risk that is faced by these individuals with cardiovascular disease following it. Myocarditis, far more common than what you get with an mRNA vaccine, around about 5 times more common if you've had acute COVID. But more importantly, on a population basis, acute myocardial infarction, hazard ratio of 1.6, CVA 1.5, atrial fibrillation 1.7. Fairly high risk. Again, if you look over on the right-hand side, far more likely in those who are unwell and those who are hospitalized. And of course, a very famous cricketer comes to mind, hospitalized acute COVID, required non-invasive ventilation. The smoking afterwards probably didn't help either. Next slide, please. So think about palpitations and chest pain. Cardiovascular risk is increased and unfortunately could be increased at least for up to 12 months afterwards. Again, assess the risk of angina and ischemic heart disease as you would always beforehand. Next slide, please. And thank you very much.
Thank you very much, Peter. That was very informative. Appreciate you joining us tonight to present. So next, we're going to hand over to Sandra Fitzgerald. Sandra is a Health Pathways clinical editor, and I'll just share a screen for you, Sandra. It won't be a moment.
So, Charles, are you going to put up the slide with the login details?
Yeah, I'll just do that now.
Okay. So hopefully this is not new to anybody. Hopefully you all have the login details for your respective health pathways and patient info sites. On the left-hand side, we have Hunter New England. At the top, we've got health pathways. At the bottom, patient info, which is not password protected. And on the right-hand side, we've got the same details for the Central Coast. And so, Charles, if I can now share my screen, that would be terrific. Thank you so much. Can you see the Central Coast health pathways?
Yep, looks good.
Fantastic. And so just to say that both Central Coast and Hunter New England have got a post-COVID conditions health pathway. So that's the Central Coast one set out in our usual health pathway style. And this is the Hunter New England one in the mobile-friendly site. And many thanks to Peter Walk for his input on this health pathway, and also to Michelle Redford for reviewing it and making such great suggestions to make it a clinically useful pathway for all our community. I'm just going to spend just a couple of minutes now showing you around some changes on the Hunter New England site specifically. We've given the COVID suite a facelift this week, and we've liaised with lots of GPs from right around the district. So thank you to all those people we reached out to who gave us some great feedback. The first change you'll see when you go in on the left-hand side here in the table of contents, we've made it a little bit more intuitive, and we've changed some of the headings here. So if you're looking specifically for vaccination, you go there. If you're looking specifically for clinical care, it's here. And in the clinical care pathways is where you'll find the most popular pathway, which is our care of COVID positive adults pathway. And this is the one that's had the biggest facelift. So when you click on that, at the very top of the pathway, you'll see Michelle's fantastic frequently asked questions up the top there. And at the very top, you'll also see just a quick snapshot of what's new and important. As you scroll down the pathway, we've made it all really intuitive and following the how you go about doing a consultation with patients. We think that probably the most important bits are right up the top here. We think people are probably going to look mostly at the medications, and we've put the monoclonal antibodies and oral antivirals up here in a drop down, followed by the inhaled corticosteroids. And then the next most important thing is probably the escalation criteria and referral to COVID care in the community. And that's also in here. Oh, and the other thing I wanted to show you with medications, right at the top here, in case you're looking for that fantastic comparison table that Michelle Redford has put together, we've got it linked here as the very first thing under monoclonal antibodies, so you can find that there for your quick reference. So please take some time to familiarise yourself with this new pathway. Hopefully it's very intuitive and you'll be able to find what you need very quickly. After initial consultation, we've got what you might do during the acute phase with follow-up consultations. We've grouped all the things about specific populations together. So for your particularly these groups of patients, you'll find quickly and easily what you're looking for to manage those patients. We've grouped all the de-isolation things together. You'll see under de-isolation, particularly additional recommendations for people who work or volunteer in high-risk settings, including general practice, and the same household contents for critical workers and so on. And then we've got after the acute illness, which of course finishes there with post-COVID conditions and the link back to the post-COVID conditions pathway. So thank you, everybody. If you've got any feedback, please let us know. We'd love to make sure that these are all very usable and appropriate for your practices. Thanks, Charles.
Thanks very much, Sandra. So next we're going to hand over to Eden McNeil. Eden is an exercise physiologist and has prepared a presentation for us on post-COVID rehab. Thanks, Eden.
Thank you, Charles. I will just share this one and get that one up and go this way. Yep, all right. So as Charles said, I'm an exercise physiologist up in the Newcastle region, and we've been doing a little bit of post-COVID conditions and exercise recommendations. So what I thought I'd talk you through today is just some of the current research around post-COVID conditions, the symptoms that their sort of patients are reporting with or clients are reporting with, and then the recovery guidelines and sort of what exercise rehabilitation looks like post-COVID. So similar to like what Peter said in his presentation, those post-COVID conditions is a really big sort of umbrella term for the physical symptoms and even mental health symptoms that someone is getting, so that 4 weeks post their COVID-19 infection past their acute phase. So the current findings in this meta-analysis that we looked at, oh, sorry, I'll go back, my bad. So 46% of those that had COVID-19 reported fatigue lasting weeks to months. So it's sort of a bit ambiguous in terms of how long they're reporting that fatigue for. And then 23% had the fatigue sort of 21 days post that symptom onset. So for a lot of people, it is sort of lasting a little bit more, and that recovery is taking longer than I think a lot of, at least in my experience, a lot of healthy people have sort of expected. Yeah, so that's through that meta-analysis. So as Peter sort of mentioned as well, there is quite a variety of symptoms that people are reporting in their post-COVID conditions. I guess in our experience, the biggest one that we've seen in our clinic is the breathlessness and the fatigue. So that has been the most common 2 symptoms that we've seen, just based on the population that we've seen, and even some clinicians that have had it in our clinic as well have reported those to be their 2 biggest symptoms, or the 2 common ones. So as you can see in these studies here, there's been a variety of different symptoms that have been reported post-COVID. Again, sort of the fatigue and the breathlessness being the most common, with a few with the anxiety, which potentially is limiting people to getting back to activities that they may have previously participated in, or they may be unsure. So along with sort of managing the physical symptoms that they are experiencing, it's really important for us to manage and educate them around how to reintroduce those activities without creating any exacerbations of their symptoms that they are experiencing, but also helping to manage that anxiety that may be around returning to exercise or to work with new symptoms that they may not have previously experienced. And then you can see in some of these other studies that sort of 10-week mark, people are still sort of experiencing a fatigue or a symptom that is sort of persisting around there. All right, so within our clinic and within any sort of exercise rehabilitation, it's really important that we take a holistic approach. So we're looking at not only the health impacts of their post-COVID condition, but their social and economic and their work impacts. So I guess as exercise physiologists, that's one benefit that we do have, in the sense that we are sort of trained to treat people with both physical and mental health conditions, and obviously doing some return to work rehabilitation as well, to address that ripple effect that people are experiencing, that it's not just the health that is sort of taking an impact with the post-COVID conditions. You can see that this ripple effect that people experience with these symptoms or conditions is quite similar to what we would see with someone with, say, a chronic pain, chronic fatigue, fibromyalgia, or even some POTS clients as well, in that it sort of ripples out and creates a bit of an impact in all of their aspects of their life. So it's really important that we address that and get them back to doing what they love, or adjusting it to help manage them to get back to what they were doing prior to their diagnosis of COVID-19. So the best practice guidelines for post-COVID conditions, obviously being quite a new area, there's not a lot of research that's out there that we can guide ourselves off. But as I said, it's quite similar to treating someone with any sort of chronic condition that might create fatigue or muscle aches and pains and that sort of thing. So there has been, oh, sorry, go to this slide next. Yeah, so as that slide says, for most of the people, it's about teaching them to manage their exercise or return to work with their post-COVID conditions rather than afterwards. So we want to start introducing an exercise at an appropriate level that the person can manage, so that we don't prolong that recovery or that return to exercise or normality as much as we can, particularly in regards to work. We want to try and encourage people to get back to work within their limits that we can with their post-COVID conditions, rather than waiting until they're fully recovered. As you can see in Peter's presentation, that can vary vastly for people. So a couple of weeks might be okay for most people to sort of manage and go without that sort of stuff, but dragging on into months, it gets a lot harder and more challenging then to rehabilitate someone in that sense. So here is a little cohort study that was done in New York City with COVID-19 positive patients post their recovery, and it looked at four different categories. So it looked at one-on-one exercise physiology, telehealth exercise physiology, an independent exercise program, and then there were some participants that had no exercise intervention at all. So they did some really simple tests, a 30-second sit to stand for lower limb strength and a 3-minute step test for the endurance. So they were assessed at the start of the study and then reassessed 2 weeks after, and the results vary. So for the 30-second sit to stand test for lower limb strength, the one-on-one and telehealth groups reached a clinically significant improvements. However, the two other groups that had no exercise physiology or independent exercise did not. And for the 3-minute step test for cardiopulmonary endurance, only the one-on-one exercise physiology group reached clinical meaningful improvement. So what this study, I think, teaches us is that with people who are experiencing fatigue or any sort of breathlessness, they may not necessarily have any changes to their oxygen saturation levels or any abnormal heart rate or blood pressure responses. So as exercise physiologists, we can monitor that within a clinical setting and one-on-one with the patient, so we can know when we're when we are able to push them a little bit further, as long as they're still within safe guidelines of exercise, and that would probably result in further improvements. Whereas someone who is independently managing their exercise and their symptoms at home, they may not necessarily have the education around when it's okay for them to push a little bit more or complete a bit more exercise, and when it is okay for them to stop. And again, I think we see this a lot in sort of any sort of chronic fatigue or chronic pain, or even with heart or lung conditions in the clinic. It's giving them a lot of education and empowerment for how they can manage it, and when they know that they can sort of push through, and understanding building up that exercise tolerance so slowly and safely for them, so that they can make improvements. So with exercise, as with anything, not exclusively for post-COVID, but really taking a thorough history of their health and even their exercise regimes prior to COVID-19 diagnosis, and what it's been like since then. Then getting a plan in place that we use similar to cognitive behavior techniques around pacing and shaping and graded exposure to exercise, so we don't increase their risk of flare-ups. Obviously, with people who are experiencing anxiety as a symptom post-COVID, it's about slowly building them back up to get them to return to the level that they may have been at. It may also be educating people around the fact that it may take them a while to get to the level that they were at, or for some people who end up with further complications post-COVID, that they may not be able to return to the level that they were at, but finding their new normal and a new acceptable level for them to exercise at, so they can still get back to the activity or the sport or the work that they may have enjoyed prior to their COVID-19 diagnosis. A benefit that exercise physiologists can provide, and even physiotherapists as well, is that graded return to work plan. We can help advise return to work coordinators or even individuals around how to manage particularly laborious work or anything that's got quite a lot of manual handling in it, how they can best manage their return to work so they can still participate and do those activities without exacerbating their symptoms or causing a particular flare-up so that they can't do anything on their days off, or having fatigue so bad that they end up sort of sleeping through and not participating in life, and then their social aspects of their life may potentially have a bit of a downward slope and be a little bit disadvantaged. So basically, anyone post-COVID with post-COVID conditions can qualify for a rehab program within some limitations. So they basically have to have a negative test or their 24 hours of recovery of their fever, and then 7 days post-symptoms first appearing. From my experience, most of the clients and participants that we've had that have had COVID in our program, they're generally reporting that they can't do anything until their 7 days isolation is up. So most people are sort of, I guess, already self-restricting that. And then for someone who didn't have any symptoms with their COVID-19 diagnosis, they may resume after they have a negative test, or again, just since 7 days since their positive test. We do need to make sure that if there are any further complications or any further symptoms, that they get investigated by their GP. And then obviously someone with a cardiovascular condition diagnosis post their COVID-19 or a pulmonary diagnosis, can still exercise. It just changes the way that we do it. We would treat them more along the lines of their cardiovascular or their pulmonary condition rather than their post-COVID-19 condition. Again, very similar in the sense of the way it's sort of paced and graded exposure to the exercises, but you're just treating different symptoms, and you're looking at different, I guess, clinical observations to manage their exercise, rehabilitation, and return to sport, exercise, work, whatever it may be. So similar, we have some contraindications to exercise, and again, having someone face-to-face in the clinic allows us to monitor these throughout their entire exercise session. So we don't want their oxygen sats below 88% or 10% below their resting oxygen saturation, and they are complete discontinues. As it says at the top, that clearance is needed for any cardiac symptoms that weren't there prior, and I would even sort of say any sort of abnormal pulmonary symptoms that go beyond that flow chart that Peter sort of said that require further investigations. As for their heart rate, below 50 or above 40, cease exercise, and then the systolic blood pressure below 90 or above 200, again, is cessation of exercise. And then the new onset of angina, which would fall under a nice cardiac symptom for a clearance. And then obviously monitoring their exercise, the clinical observations throughout their exercise, and ceasing at any stage if any of these contraindications come up. But again, talking to the client and making sure that they are comfortable with the level that they are performing at, particularly those that may be experiencing some sort of anxiety. If they're already experiencing breathlessness post their COVID, you don't want to kind of increase that anxiety and potentially increase that breathlessness while they're exercising as well. This is just a nice little joke that we sort of added in that sort of seems to be continuing on, everyone looking forward to the next year. And so on and so forth. So, but thank you. That's me all done in the presentation. So I will hand over to Michelle for the Q&A. So thank you everyone for listening.
Thank you, Eden, Peter and Sandra. That's great. I do have to just say that unfortunately Stephen couldn't make it tonight, and so we're unable to have his presentation, but we are going to just jump right in with the Q&A. So if all the presenters can just make sure that their camera is on and they're not muted, and we'll get started. So Eden, I think the first question is probably for you, if that's okay.
Okay.
So the question is about, can we refer to exercise physiology with an EPC under a GP management plan and team care arrangement?
Yes, you most certainly can. We are on there with all other allied health professionals. So yeah, you can refer to EP on an EPC care plan.
And what sort of information is helpful for you to get from the GP? What's, what sort of things are frequently missing that would be useful?
I guess most GPs are pretty good at sending a full health history along with the referral, so that can be handy because sometimes clients don't necessarily know what is in their history or what may be relevant to an exercise physiologist if they had to monitor certain things or adjust the exercises. So I think that and any medications that they may be on is probably the most helpful, particularly if they're on some cardiac medications. We know that heart rate may not be the best clinical observation to look at if they're on a medication like a beta blocker or something like that that's limiting their heart rate. So we need to use other methods to monitor how they're tolerating the exercise.
Yeah, excellent. So really the sorts of things that should be in a clinical summary, and so it should be fairly easy for us to share that information with you so that it helps, yeah, and keeps everyone safe. Okay, that's great, thank you. I suppose there's a few other questions. Some of them have been answered, but I can still go through those. I'll just check what's happening. So one question that keeps coming up is about being positive and when can you go back to work. So the question is, I've tested positive and still got cough, congestion and fatigue even after 10 days of isolation, but when can I go back to work? So which is a good question, and it's something that comes up a lot. So the official guidance, if you are not immunocompromised, is that if you've still got symptoms at day 10, really you should have some clinical input from your GP. You're very unlikely to still be infectious, as we found out at the last webinar, that you'd be very unlikely to be infectious beyond day 10. So it's more the clinical assessment of why you're still unwell, and all the guidance really is that beyond day 10, if you're not immunocompromised, then you're okay to return. If you're immunocompromised, it's day 15 with 2 negative rats. So hopefully that answers that question. I will just, actually I've got a question for Peter. Peter, if you're there, are you okay to answer a question? It's about sure. The availability of respiratory function testing. So I know that with the sort of aerosol generating procedures, a lot of practices have stopped doing spirometry in-house, and I don't know if that's had a knock-on effect for the hospital and for other providers, and now there's potentially this need to measure people's DLCOs and things. Do you think there's capacity in the system?
Yeah, I mean, so yeah, we were all impacted by COVID as well, and that has caused delays and backups, and all of those factors are part to play now. Our understanding of what generates aerosols has also evolved over the last several years, and there was a lot of concern around lung function testing. Anything that gets the person to cough or exercise and increase their ventilation is going to increase the risk of spreading any infectious disease. So doing spirometry is probably no worse than doing an exercise test, or clearly isn't any worse and probably less difficult than doing an exercise test. And while there is recommendations on guidance and wearing PPE whilst you're doing the test, it can be done. DLCO is actually less likely to produce coughing than spirometry. In the Newcastle area, you've got 3 laboratories that can do spirometry DLCO, and you can refer to. That's at Maitland, at Charlestown, and of course at John Hunter. And Central Coast has got 2, I'm pretty sure. So yes, there's going to be some limitation. All the labs are back to doing work, particularly spirometry DLCO. Bronchial provocation challenges remain a bit of a work in progress.
Excellent. It's good to know that that is available. That's excellent. So that's always going to be a question, you know, about availability. So I think Stephen is actually here. So sorry for the delay, and Stephen is able to join the panel. If there are questions for Stephen, that would be wonderful. Pop them in the question box and we'll continue to go through the questions. So just going through some other questions that came up. So one of the questions was, is the notification to GPs that I was talking about the same as the admission notification? So I'm not quite sure how this works on the Central Coast, but in Hunter, New England, you do get an automated admission notification if Hunter, New England knows that you're the GP. So that means you've previously been identified in their clinical system. But all that tells you is that that patient has COVID. It doesn't tell you that they're being looked after in any way, shape or form. And so that is definitely very different to what is coming through more recently from New South Wales Health and Medibank Private, which is direct contact to the practice. And if they can't get hold of anyone at the practice, or the GP at the practice doesn't have the capacity to do those assessments for antiviral medication, then that's handed over to the LHD teams at the moment. So that's the process. I'm not sure how clearly articulated that has been to GPs up to now, but that is my understanding of the process. What else have we got here? We've got medical staff having 20 to 30 minutes unmasked contact with a COVID positive other staff member. Okay, and what do we do? So these close contacts in general practice are a real risk to service continuity, aren't they? And I think that gets back to my favourite topic, which is managing the tea room, which I might have mentioned at every previous webinar so far. And it's hard to do. Like it's a shame we don't see each other face to face in the same way that we used to, and you know that is important. But if you have 20 to 30 minutes face to face with a COVID positive person, and no one's got a mask on at all, and you're within 1.5 meters, potentially you're out of action for 7 days. So the New South Wales Health Risk Matrix takes you through that across various scenarios. So if it's more than 15 minutes within 1.5 meters, that is a higher risk scenario, unfortunately, and to be avoided if you possibly can. If you can put in some other controls to stop that happening, it's very tricky. So that's another question.
Michelle, can I just jump in for a second? One of the pathways I forgot to show was, it's a new one as of today, and it replaces the practice management pathway, and it is called, let me just get it completely correct, infection control and staff exposure or infection, and those risk matrices are there in that pathway.
Wonderful. So we don't need to go hunting for them. They're just there, ready for us.
Yes. In the table of contents under practice setup, it's the very first pathway.
Wonderful. Okay, have we got any more specialist type questions? Whilst we've got specialists, got questions about some GP management plans. I guess, Stephen, it would be really helpful to get your ideas about, you know, what the key roles for GPs are in managing post-COVID conditions, what are the key things that we shouldn't be missing, and the key things that we should be doing, if that's possible, Stephen.
So unfortunately, Sandra, Stephen still hasn't been able to join our panel.
Oh,
I think we're having a couple of technical issues just getting him the right link to join. So I'll keep an eye out, and if he joins, I'll let you know. But at the moment, we still don't have Peter on our panel, unfortunately.
Oh, thanks,
sorry,
Charles.
Stephen on our panel. We've got Peter. Thanks, Michelle.
Thank you. So more GP questions coming in. Look, so Sandra and I will go on these. So are the GPs expected to follow up all patients notified to them as tested positive? No, not really. So there's not really a definite expectation of GPs. The people that have tested positive that you're notified will have gone through this screening process through the New South Wales Health notification and will have answered the questions that come to them by text. And if they haven't answered the questions, then they're prioritised for a phone call from New South Wales Health to ask them the questions and find out where their risk sits. But I suppose what I do is you know, if they're my patients and I know who they are and I know that they're immunocompromised, or I know that they've got type 2 diabetes and they're 82 and they're evidently at high risk, then I do make contact with those people, because often that's the first time I find out about them, and it's going to be much sooner than finding out through any other way. And a lot of those people are going to be pulse oximeters, and they're going to need pulse oximeters and some clinical follow-up, whether or not they need medication. So that's what I would do. There's not some big rule about it, and it's going to be dependent on how much capacity you have in your practice to do those sorts of things. So the safety net really at the moment is answering the questions that come through from New South Wales Health. And so if you do get the chance to talk to people about that, then encourage them to do it, because that's the mechanism for picking up those higher risk patients at the moment. Does that make sense? Does anyone else want to jump in on that? I don't know if Peter knows more about that and how all the back end of that works.
No, I think that's a pretty good summary, Michelle. Yeah, if the patient's filling in the survey, the Services New South Wales survey, it will come both to the LHD as well as to the PHNs and then onto the GPs. So there are hopefully a couple of safety nets in place there. But not everybody. That's certainly not the intention, is that everybody who's becoming positive would need to be followed up, and clearly they don't.
No, and the vast majority of people, as you know, I'm sure everyone has experienced a whole lot of COVID amongst their patients. I certainly have, and the vast majority of them are not too unwell, thank goodness, and are perfectly managing themselves at home. But I think it's good to be aware that they have COVID, so that if you know that they have particular social or medical needs, potentially you have that opportunity to reach out if you have capacity. So I think that's where it's sitting at the moment. Let's have a look at these other questions. I don't know, Peter, if you had anything else that you wanted to add, or
I guess look, we're trying to put together some general advice. There's going to be a lot of people out there that are very concerned following their COVID illness, and what we don't want to have happen is that they come in and they have their 10 symptoms that they present with, and we don't want that to then just lead to a whole series of investigations and referrals to a whole series of specialists who'll do more investigations. So thinking about the problem and the impact on their quality of life, and probably intervening early with some things such as if they don't really have very severe breathlessness, getting them into self-management programs, getting them to exercise themselves, or getting them some supervised exercise programs early on probably make a world of difference and would be very good for them on many levels anyway. And it's really only reserving for those people who've got quite significant symptoms that are impacting upon their quality of life, that we'd want to start to think about them and then investigate. The LHDs are mindful, and New South Wales Health is mindful that there will be a cohort, hopefully not a huge cohort, but a cohort that are going to be more complex, in whom there will be lots of questions raised, and perhaps they do need to be seen by more than one subspecialty team to get assistance. I would think that some of those individuals should be really obvious and should actually be known to the system, because they're the ones that were very unwell in intensive care or had prolonged hospital admissions, and so should already be in the system and known to the system, and we should be already actively involving them in rehabilitation programs as we speak. But there will be efforts to try and put together some multidisciplinary triage processes in place, also to direct people a little bit better and a little bit more efficiently. And we'll turn and hopefully go to Sandra for assistance in allowing that sort of thing to happen, and perhaps going through health pathways, working through that, and then putting some links there for the appropriate services to refer to is where we would hope the clinical practice guideline is going to end.
And I think for GPs, Peter, I think some of it is just familiarity and that, you know, what is normal post-COVID, and being able to reassure. And as we become more familiar and we see more patients presenting with that breathlessness and fatigue, I think that will help us to calm our investigations a little bit as well. I think we can become more confident as we get some more clinical exposure. And then, yeah, as you say, filtering out those ones that really need a bit more.
Yeah, and look, these are common symptoms, but for the vast majority of people, they will actually improve. And if the impact isn't great, they should continue to improve and resolve completely. And so they're certainly real symptoms, as are all those things that are mentioned. I think acknowledging that they're real symptoms and acknowledging that they're related to the illness is probably part of this. And where appropriate, people are going to need investigations, but but reassuring those same individuals that this is somewhat to be expected, I think is going to be really quite an important role for all of us.
And really utilising our allied health colleagues and getting people moving when they're able to is going to be helpful. And I saw quite a few resources coming out of the UK, I think, about those sort of self-guided management programs that you mentioned as well, those sort of self-guided exercise.
Yeah, we're just looking through them now, and they look great. I mean, a lot, very similar. And look, we had these same concerns when we turned the acute management over to the individuals as well, when Omicron just got out of a bottle. But we're going to have to do the same thing here.
Yeah. Okay. Now, I don't think that any more questions have come up, and we're pretty much on time to finish. So I might just hand back to Charles for a wrap up, if that's okay,
great.
Charles.
Sounds good to
Thanks,
me.
everybody.
Thanks very much. Thanks for those great questions coming in. Thank you to you all out there for joining us this evening and spending your night with us. I would also like to take the opportunity to thank Peter, Michelle, Eden, Sandra and Kim. You know, there's a lot of time that goes into preparing the information that you do for us, and I don't think that always gets recognised. So we do appreciate the time you've taken, not just tonight to present, but to prepare all of your great information. So as I mentioned at the start, the session has been recorded. So if you'd like to rewatch it, or if you have a colleague that missed it tonight, they can rewatch it in our education library on our website, and we should have that up tomorrow for you, along with our presenter slides. So there will be a short evaluation survey, and that'll pop up in a moment when the webinar ends. If you could just take a minute to fill that out before you log off this evening. We always really appreciate any feedback that you can provide us on our education sessions. So that's all from me. Thanks again, everyone, and we wish you an enjoyable rest of your evening. Good night.